Welcome to the Deep Dive. Today we're getting into a body of research that really challenges one of the most fundamental and widely used classifications in oncology.
It's a classification that, as the sources argue, might be dangerously misleading.
We're focusing on a subtype of breast cancer that's widely misunderstood, often undertreated, and, well, potentially responsible for thousands of avoidable deaths.
Our mission today is to analyze the sources arguing for a really seismic shift in how we think about a highly fatal breast cancer, one that's currently diagnosed, most of the time, simply as ductal carcinoma in situ, or DCIS.
Right, DCIS. For decades, that's been seen as a non-invasive precursor, almost like a warning sign.
Exactly, a warning sign, but that's not what the evidence we're looking at today suggests.
So the core premise we're exploring is that this specific aggressive cancer is not in situ. It's not contained. It's actively and aggressively invasive from the very start. The sources are proposing a new term for it, ductal adenocarcinoma of the breast, or DAB.
And this is so vital because we're looking at the consequences of, well, clinging to historical pathology terms when they just clash with the clinical reality.
If the name says benign containment, but the reality is lethal metastasis, then the name itself is the problem.
That's it. The nomenclature is creating a massive risk for patients. We need to really understand the evidence here.
Okay, so let's unpack this central conflict. The sources point out that this isn't some rare subtype. We're talking about approximately 20% of all breast cancer patients.
20%, a huge number. And these patients have a malignancy with these specific ductal features, but it's routinely being diagnosed as DCIS, maybe with a small note about microinvasion.
Despite its truly aggressive nature.
And that aggressive nature is often something the patient and the physician can physically feel. You know, we often think of breast cancer as a single, hard, distinct lump.
A little marble or something.
Right. But these DAB malignancies, they're often found as a diffuse, palpable thickening of the tissue. It can cover a really large area.
And the size. I mean, the size is huge. We're talking 5 centimeters or even larger by the time they're detected.
Exactly.
So if you have a 5-centimeter malignancy that's spread out, why would any pathologist accept the term in situ? I mean, it literally means in its original place. What was the logic there?
That is the absolute crux of the problem. Historically, the in situ label was based on what looked like an intact myoepithelial layer. That's the little sheet of tissue separating the duct lining from everything else.
So as long as that layer looked okay?
As long as it appeared intact, the cancer was called non-invasive. It didn't matter how large or how high grade the tumor cells inside were. The sources we're looking at argue that focusing on just that one microscopic layer is, well, completely insufficient for this specific cancer.
So we need the new term, Ductal Adenocarcinoma of the breast, or DAB, to make it clear this is a truly invasive subtype. And what's fascinating is that this isn't a new idea. It's more of a rediscovery.
It is. We're sort of reconnecting with old, forgotten pathology. This exact subtype was actually described almost 100 years ago.
100 years.
Yes, by a leading pathologist named Bloodgood. He called it adenocarcinoma comedo, or duct cancer. It seems modern pathology just simplified things over time, and that clinical reality got lost.
And to give us some context on just how serious this is, the researchers say DAB is very similar in appearance, biology, and prognosis to ductal adenocarcinoma of the prostate, DAP.
And that connection is so powerful. It takes this cancer out of that benign-sounding DCIS box and puts it squarely where it belongs with aggressive, life-threatening tumors. Tumors we know need aggressive treatment.
Okay, so let's get into the core of the invasion. If this thing is spreading, how does it do it? This brings us to the biological mechanism that really sets DAB apart, which is Neoductgenesis.
Neoductgenesis. It's literally the process of forming new, abnormal, and really disorganized duct-like structures.
So it's building its own highway system.
That's a great way to put it. The cancer cells that start in these large ducts, they don't just sit there. They use this mechanism to continuously produce these new, branching, abnormal neoducts that push out into the breast tissue.
So the cancer is actively creating its own invasive clumping. How does it physically do that? What's the cellular process?
It's a mechanism called epithelial mesenchymal transformation, or EMT. Just think of it like a cellular state change.
Okay.
Epithelial cells are usually static, organized, but mesenchymal cells are mobile, they're robust, they can invade. When the cancer cells go through EMT, they transform. They can then break down the walls of the duct and invade the stroma by forming these new branches, the neoducts. The process is, by its very definition, invasive.
Wow. So it's not waiting to invade, It's actively tearing down its own house and rebuilding it into this branching, lethal structure. What's the microscopic evidence for this? What markers prove it's happening?
You see three really undeniable indicators. First, the neoducts themselves. Under a microscope, they're irregular, they're tightly packed, and critically, they don't have the normal little sac-like structures, the TDLUs, that you'd see in healthy breast tissue.
Which proves they're newly built and chaotic.
Precisely. And what's indicator number two?
The microenvironment. The tissue around the neoducts is reacting like crazy. You see what's called a desmoplastic reaction.
So the surrounding breast tissue is hardening up.
It's hardening and changing its structure.
Yeah.
It's recruiting these special cells, cancer-associated fibroblasts, or CAFs, and you see all this lymphocytic infiltration. And the research suggests this isn't just the body trying to protect itself.
No.
No, it suggests the cancer might actually be hijacking this process, recruiting those CAFs to help it build scaffolding to advance even faster.
So the body's attempt to wall it off might actually be helping it spread. Okay, what's the third, maybe most definitive marker?
That would be the overexpression of tenascin C.
Tenascin C.
Yes, and this is a powerful finding. Tenascin C is a protein, a beta-glycoprotein, and it's only produced at sites where epithelial cells are actively remodeling the connective tissue around them.
So it's like the contractor sign, proof that new invasive construction is happening.
Exactly. Pathologists see a thick layer of it surrounding these neoducts. It's clear molecular proof that these structures are new and they are invading.
And what about that protective myoepithelial layer, the one that was so misleading?
Right. Well, while it might look like it's there, the sources show the cells in that layer, the MECs, are abnormally shaped. They're immunophenotypically different. It's a corrupted, abnormal layer. Relying on its mere presence to say non-invasive is what leads to this dangerous undertreatment.
And of course, a rapidly growing cancer needs a ton of energy.
A massive amount.
Yeah.
Which leads to neovascularity, the formation of all these haphazard, contorted new blood vessels. And maybe the most damning evidence of all, the source material notes that this Neoductgenesis, this new duct formation, has actually been found in the axillary lymph nodes.
In the lymph nodes?
Yes, and if the defining feature of the tumor is in the lymph nodes, it is by definition an invasive and metastatic process. That is the biological smoking gun.
That's just an incredible level of activity happening. So if you have all this malignant remodeling going on, how did that chaos actually show up on a mammogram? What does a radiologist see?
This is where we get to the imaging biomarkers. The most characteristic sign is these very specific intraductal calcifications. They're described with these really powerful visual terms like casting type, linear and branched, elongated bizarre, or arborized. They look fragmented and bright white because they're literally filling the mold of this chaotic new ductal system.
So you're not seeing little specks, you're seeing these fine, complex lines that branch out almost like what, the roots of a tree or a river system?
Exactly. And they're often massive. They can fill an entire lobe from the nipple all the way to the chest wall. They visually confirm the huge scope of the disease. But, and this is a critical warning for surgeons and radiologists, the visible calcification is only the historical extent of the tumor.
What do you mean by historical extent?
The true viable malignancy is almost always much larger than what you can see on the mammogram.
Why is that?
Because the most active parts, the growing tips, those branching neoducts at the periphery, they haven't had time to calcify yet. The source material is very clear. If a surgeon only removes the tissue defined by the calcification,
You're leaving cancer behind.
you are guaranteed to leave behind the most actively growing part of the high-grade malignancy. You're leaving viable grade 3 cancer cells in the patient.
So the current surgical approach, which uses those calcifications as a guide, basically ensures incomplete removal for these patients. Undertreatment is built right into the process.
It is. Because the malignancy is so extensive, nipple to chest wall, these patients are generally poor candidates for breast-conserving surgery. It requires incredibly thorough imaging, including MRI, to define the full scope and prevent recurrence from those residual cells.
Which brings us to the statistical reality, the outcomes. If this is classified as non-invasive, the long-term fatality rate should be close to 0. But that is not what the studies show.
Not at all. And this is the core disconnect, and it's just stark. The high fatality rate with DAB is fundamentally inconsistent with an in situ diagnosis. The lethality is directly tied to the massive tumor burden and the high-grade cells created by neoductgenesis.
And to make it even more complicated, DAB is often found alongside a totally different kind of tumor, an acinar adenocarcinoma of the breast, or AAB.
So you have two different tumor types together, and it's critical for you to understand which is which. Why is that?
It's vital because AADs are those classic small spherical lump cancers. When a clinician finds both the widespread DAB and a small AB, they often base the entire prognosis, the entire treatment plan, on the size of that small, easily measured AAB.
Giving a false sense of security.
A completely false sense of security. They're basically ignoring the massive branching DAB component that's the real threat.
So let's get to the aha moment data. This is where the numbers are just staggering.
Okay, so the research looked at a study of women with small 1 to 14 millimeter AAB tumors. A small tumor, you'd think, means a good prognosis. But in this group, only 7% of the cases also had this associated DAB. Just 7%. But get this. Those 7% of patients accounted for a devastating 37% of the total breast cancer deaths in that entire group over 24 years.
Wait, say that again. 7% of the patients caused over 1/3 of the deaths.
That's right. It means the presence of DAB, marked by those casting calcifications, is the single most dominant factor in that patient's long-term survival. It's far more important than the size of the associated lump.
It's unbelievable. To drive that home, the survival rate for women with a tiny 1 to 14 millimeter AB with DAB is about the same as for women with much, much larger tumors. We're talking 20 to 49 millimeters that did not have DAB.
So the DAB itself increases the mortality risk exponentially.
It sounds like we've been treating the wrong target for decades.
Yeah.
What do the sources say about why DIB is so resistant to our standard treatments?
They indicate that it often shows this profound resistance to traditional adjuvant therapies. So postoperative radiotherapy, chemotherapy, they've shown a very limited impact on improving long-term survival for these patients.
Which points to a unique treatment-resistant stem cell origin.
Almost certainly. And compounding this failure is a critical failure in biomarker testing, which means we're missing chances for targeted therapy.
How so?
Well, when a surgeon removes both types of tissue, it's common practice to do the biomarker testing like for HER2 status only on the small, discrete AAB lump.
Okay.
And that AAB is often ERPR positive, which is good, but critically, it's often HER2 negative.
Giving the patient a seemingly good biomarker profile.
Exactly. A misleading one. Because the high-grade lethal DAB component filling those ducts, that component is generally HER2 positive.
Oh, wow.
So the failure to specifically test the DAB cells means patients are being denied access to highly effective therapies like trastuzumab. We're undertreating the most lethal part of their disease.
So what does this all mean for the future? The research we've analyzed makes a really forceful case here. Neoductgenesis is an invasive metastatic malignancy. It is not DCIS.
The terminology has to change to reflect the reality of the high fatality rates, the massive tumor burden, and the therapeutic resistance.
Following this research, it seems we need to focus on two major areas immediately.
The first is obvious. Formally change the terminology. Recognize DAB as an invasive cancer. That changes the entire conversation for both the doctor and the patient. They have to recognize the stakes. The second is developing custom-tailored therapies that specifically target the biology of DAB.
Because our current treatments are not working well enough. And we have to improve detection. The only thing that seems to help right now is catching it extremely early.
Which means we need more effective mammography viewing techniques, specifically using enlargement and proper window leveling to spot those subtle casting calcifications when they're still very small. And it means we need reliable artificial intelligence, training AI to recognize these patterns before the tumor ever becomes palpable.
This has been a really profound deep dive into this deadly gap between medical naming and clinical reality. We've seen how a classification based on one microscopic detail can mask a widespread lethal disease. So here's a final provocative thought for you to mull over.
If a widely accepted, seemingly non-invasive cancer diagnosis is actually hiding a highly fatal treatment-resistant disease, and that misclassification is dictating the fate of thousands.
What other fundamental classifications, not just in oncology, but across all of chronic disease management, are similarly overdue for a complete, evidence-driven reevaluation based on long-term patient outcomes?
The evidence is certainly clear in this case. Knowledge is the first step toward correcting what could be decades of diagnostic error. Thank you for diving deep with us.